Hi, and welcome to GRS Facebook Live. Today's topic is genetic screening of embryos and how to select the best embryo for transfer. We're going to talk with Dr. Michael Tucker, who is embryologist at GRS, and we'll be talking about some exciting news in the next couple of weeks about GRS and merging with Shady Grove Fertility. We're going to become a Shady Grove Fertility, but you also have some exciting news to share as well, Michael, about your position.
Yes, thanks for the introduction. I have been a long-time scientific consultant with the Shady Grove Fertility Group, and as well as being scientific director here at Georgia Reproductive, I'm now actually becoming scientific director for all the Shady Grove Fertility laboratories throughout the country, and more of that to come, so thank you.
Okay, so let's dig right in, and we've got some questions that have been sent in from listeners that we'll try to get to, and if you're online, please, subscribe to this broadcast and to future broadcasts so you're aware of what we're doing, and you can send in questions. If we can't get to them today online, we'll be sure to respond to them by a message later on. So we hear about PGS and PGD as genetic screening that's done with IVF. Why are there two different ones, and what do they mean, and when do you do each?
Well, anybody who's had anything to do with assisted reproduction knows that we're full of acronyms, and they get a little crazy sometimes, but the PGS and the PGD both stand for forms of preimplantation genetic screening, in one case PGS, which is for generally chromosomal number, euploidy, aneuploidy. And the PGD stands specifically for preimplantation genetic diagnosis, where single gene defects are involved. So drilling down and trying to actually discern which embryos specifically have a genetic disorder or not, as opposed to the PGS, to go back to that, where we're actually counting chromosomal number in the embryo to see if its chromosomal status is normal or not.
So PGD, you kind of have to know what you're looking at, or what kind of disorder you're looking at before you go ahead and do the testing. And how do you figure that out to look for something like cystic fibrosis or spinal atrophy or one of the hundreds of conditions that might be involved?
Well, traditionally, we probably would have had patients present who have had some experience or something which has prompted them to recognize that they have a specific genetic disorder. But in recent years, the prevalence of genetic screening for many different forms of mutations leading to just genetic disorders has become much more routine, thanks to the improvements in genetic testing in general. So it is much more common for us to actually propose that all our patients consider relatively low-cost genetic screening for what is known as carrier status for any genetic mutations, which may not be expressed in them, but in combination with their partner. If their partner happens to be a carrier for a genetic disorder that matches up, it is potentially conceivable that they have an afflicted child. So it's perhaps becoming more common, perhaps, for us to apply single gene preimplantation genetic diagnosis now, or PGD.
So that I think is important. People can carry the mutation and not be affected. In rare cases, some of the mutations are going to have and play a role even on the carrier. But in going ahead and looking for problems with the offspring, most of the time, you would need a mutation for the same disorder from the husband and the sperm donor, both,
correct.
Both people. Can you do them both at the same time in a given case?
Yes, you can. The genetic screening, the genetic diagnosis for the single gene may take a little bit longer to perhaps there may be a need for a reference genetic lab to have to develop specific probes for an individual couple. But by and large, certainly for some of the more common genetic disorders, you can undertake both the chromosomal number count, the PGS, as well as a single gene diagnosis as well on the same biological material, that is the cells that we take out of the embryo. So just one biopsy gets the job done for both.
So this is kind of a two-part question. And the first part, is it harmful to the embryo to remove cells? And in the past, we did the biopsies on the third day, and we waited until the fifth day when we got our results back. Everybody worked double fast, and hopefully there was not going to be a FedEx problem getting the cells to the lab for testing, right. And we'd get the results back and do a transfer. Now we end up waiting till the fifth or sixth day to actually do the biopsy and freeze the embryos and come back. So does that freezing adversely affect the embryo, and why day 5 rather than day 3?
Well, I could probably speak for an entire half hour on the evolution, the changes in technology in our area of medicine has been quite profound in the last 10 years. But let's put in to place two very key developments. One has been the massive increase in use of extended culture of embryos out to day 5 or even day 6 following the day of egg retrieval. And that is the entire period, preimplantation period of embryonic development that we can control. Beyond that, it's time to put the embryo back. It needs to implant. So we have the privilege effectively to be able to keep embryos fairly happy in culture for almost up to a week. And what is that? That's enabled us to, in gaining confidence, reach a point where we have grown embryos past day 3, which was the day we would biopsy routinely previously, where an embryo would have somewhere in the region of 5 to 8 cells or so, and you would just take 1 or occasionally 2 cells. Now, because we grow pretty much all our embryos out routinely to the late stage, what's referred to as a blastocyst stage, these embryos are much better to biopsy for one significant reason: is they've gone through many more cell cycles. They have begin to differentiate into 2 cell lines, one that is going to become the embryo or fetus proper, and the other cell line which will become the actual sacs that in which the embryo and the fetus will ultimately grow. And it's those outer cells, referred to as trophectoderm cells, that now present us a much easier opportunity to go in and biopsy. And because there are many more cells in those embryos, routinely averaging 100 to up to 200 cells, when we remove between 4 to 8 cells in a biopsy procedure, we're actually removing a much smaller total part of the embryo. So that enables us to get more genetic material to give us a better take on the genetic constitution there. It also potentially damages the embryo less. You're removing a much smaller part of the embryo mass. And then finally, because the embryo is actually ready to be put back into the uterus to implant, we then have one extra piece of the puzzle, which has been the massive improvement in cryopreservation technology in recent decade, using vitrification, which effectively causes minimal damage during cryostorage. So we routinely see somewhere in excess of 98 to 99% of all embryos that we cryopreserve now survive that process extremely happily. So those two major components, the extended culture being much more effective now, and the vitrification means that we've got a lot more breathing space. We can get more genetic material, and we can store our embryos as long as it takes for us to get feedback on the biopsies undertaken.
How does age affect the likelihood that we will find embryos with an optimal implantation potential in doing this test?
Well, there's been quite a lot of talk in the lay press in recent months about a study undertaken on correlating paternal age. So I think it's important for me to point out here that we're talking not just maternal, a woman's age as she comes into it, because classically there is definitely a distinct fall off after the age of 35 onwards in terms of or not fall off, there's a fall off in implantation potential, and the main reason for that is due to the greater rate of chromosomal errors in the eggs that women produce at older ages. But interestingly, in recent times, it's become clear that there is a similar impact in men, albeit kicking in at later ages. You're probably looking at 50 and onward, where you get higher incidence of chromosomal anomalies in the sperm that men produce. So yes, age has a very distinct impact, and it certainly does justify, medically justify a potentially a greater need, if you will, for going in and screening, and that's using PGS for chromosomal number to check on the euploidy status, the chromosomal normality of embryos arising from older women, biologically speaking, reproductively, and even now in men at an older age.
So when I get a report back after the biopsy has been done, it says normal, and we've always seen that normal as indicating this is a normal embryo, but not every one of those embryos goes on to make up a viable pregnancy. We also know that we're looking at just 5 cells or 4 to 8 cells out of 120 cells in that embryo.
Right.
Are there cautions in how we as physicians or patients should understand the results of this sort of testing?
Well, let's start with PGD. The gene screening, I think, is a much cleaner test, if you will, in this case, because you're really drilling down on one specific defect and looking if a mutation is present or not, or whether carrier status exists or not. That's a much more binary, it has it or it doesn't have it, or there's some issues over recessive and dominant genes there, but let's not go into that right now. But when it comes to the PGS chromosomal screening status, it's almost too binary to talk, as we're coming to realize now with newer technologies in terms of genetic screening in general. Probably notably out there, the one that gets talked about in the newest development is next generation sequencing, high resolution next generation sequencing, or NGS, for chromosomal status, has begun to make it clear that perhaps what we need to do is talk about embryos which have a higher or a lower implantation potential, as opposed to coming up with terms as binary as normal or not normal. So perhaps I'll throw it back to you to dissect the issue in terms of chromosomal number and how that gets a little bit confusing in terms of whether you have a certain number of chromosomes, say 13. Is there one chromosome 13, or two chromosomes 13, or three chromosomes 13? Sometimes there's some gray area in that where it can get a little confusing, and that brings us perhaps to to mention the topic of what's referred to as mosaicism. And that gray area starts to creep in when, in having taken out, say, 5 cells, not all 5 cells are giving you the same answer. So that's where you start running into a gray area, suggesting that perhaps normality or otherwise is too simplistic an approach to refer to the status of the embryo.
I think it's also going to be important that this kind of information, while we have seen data to suggest that people who have an embryo that's screened, quote, normal, are going to become pregnant faster than those where a random embryo is selected. And it's easier for patients to feel comfortable putting a single embryo in when we tell them that the embryo is screened normal. And I think that's important. Lowering the risk of multiple births is something that I think this technology allows for. And if the couple is approaching their late 30s and they're thinking about having more than one child, if they have a number of embryos that are come back and are shown as euploid, meaning the correct number of chromosomes, their potential for a second pregnancy down the line would be higher than if all the embryos tested abnormally, and they may wish to do a second cycle to bank embryos for that next child down the road. But I think we need additional methodology before we can say that this embryo is normal or this embryo is going to implant and make an offspring. One of the issues that's come up is we've changed some of the procedure when we're doing the biopsies on day 5 now. We are cryopreserving the embryos or vitrifying them and then coming back at a later time. When we have more controlled response in the endometrium, we have better control of the hormonal stimulation. And some studies have shown that in the patient who makes a lot of eggs and has a high estrogen and a high progesterone level, that implantation in that fresh cycle may be reduced. So this provides the benefit of reducing ovarian hyperstimulation syndrome and transferring in a better uterine environment.
Natural, yeah.
The question comes as to whether some of the improvement we may see in those later transfers are due just to the vitrification and a delayed transfer.
Yeah, I mean, certainly there's some confusion in the studies that have not dissected out those two elements entirely clearly. But I'm a great fan of vitrification because whether you undertake biopsy or not, I think it gives you a much more flexibility in how you approach your, enabling embryo banking and the like into the future. But in particular, I think one of the greatest beneficial impacts, has been the ability for us to cryopreserve on a routinely efficient basis, has really promoted the approach to single embryo transfer, which has been a profound improvement in our industry, not creating so many twins or multiples in general.
So who should be considering undergoing? Obviously, if you have a known genetic risk for a single gene defect, such as cystic fibrosis or sickle, those people should consider PGD. But what situations might PGS be considered?
Well, I think probably key to this is anybody's tolerance with the potential, because what we're talking about is the potential to end up with quote unquote no high potential good quality embryos for transfer following the PGS screening approach. Now, if you tend to be a high responding patient who is younger, it is certainly can be a very effective tool, because it is quite conceivable to end up with a dozen or more embryos which may be cryopreserved. And PGS can certainly act as a very effective filtering tool to drill down on those embryos perceived as normal as opposed to not, which allows you to get to transfer of a higher potential implantation potential embryo sooner, so effectively your time to pregnancy can be improved, and also your perspective on what your potential of adding to a family. Now, not every embryo that we transfer, even following PGS screening, as you mentioned earlier, necessarily will implant, but certainly the PGS screening does take up the overall level potential for implantation, because it's one extra positive filter, if you will, to screen out those embryos with lesser potential. So that's one good scenario. Patients high good prognosis, perhaps who have a good number of embryos, and then as we referred to earlier, those of advancing maternal age certainly could use PGS as an effective tool to screen for potentially higher rates of aneuploid or chromosomally abnormal embryos. So there's certainly that spectrum. But then anybody in between, and certainly one of the areas, the ages that seem mostly suited to this, because they tend to be still good responding but start to get into that higher risk age group, are those patients over 35, certainly running up to 40, who still have very good responses. And that is key, because anybody undertaking IVF, couples, certainly any of those who have, know there is a massive or potentially a high attrition rate between the number of eggs you retrieve to the number of eggs that fertilize normally as discerned by the embryologists, and ultimately of those embryos, not every fertilized egg on the day after egg retrieval will successfully grow out the entire period of to the preimplantation limit out to day 5 or day 6. Not every one of those embryos will make it in terms of continuing to develop. And in fact, on average, you see somewhere in the 40 to 50% range of all normally fertilized eggs will become a blastocyst. It then has to be of sufficient quality to be able to be biopsied. So sometimes we'll have couples turn around and say, but we started with 15 eggs, we only got 10 embryos, and then only 5 of them made it to be biopsied. So you have to be cognizant of this fall off attrition rate, if you will. So it's absolutely key to have a good number of eggs to start with, hence refer back to the good response, to enable you to have a good cohort of potential embryos to be able to biopsy and screen. So there's so many things to discuss in this equation.
One of the things that patients will report when they come in is, I've been through IVF before, and they said my embryos were beautiful, but I didn't get pregnant. When you look at doing the biopsies and the biopsy result, are the ones that come back as euploid, meaning the correct number of chromosomes in the biopsied sample, do they tend to come from the prettier embryos? Do you have to look picture perfect to end up with a baby from the embryo?
No, and certainly having come from an era of decades of transferring embryos, sometimes that I felt were far from picture perfect, it is certainly the case that you can still get a beautiful baby from what from an embryo standpoint, looks like a pretty ugly duckling. While we have to have a certain level of cells number in the external cells in the trophectoderm to be able to biopsy, and just sometimes realistically, if there are only, say, 10 to 15 cells in that outer layer, we are really not in a position to go in and be able to biopsy that kind of embryo. It is quite conceivable we may make the choice to cancel the biopsy and just undertake either a transfer or simply cryostore that without the biopsy. And it is not always the case, certainly not always the case that those embryos implant. So the morphology has been, how should we say, the classic tool to discern implantation potential. And there is a very strong correlation between the quality, if you will, the aesthetic quality, morphology. The better an embryo looks, the higher its implantation potential. There's quite a strong correlation there, but it is certainly not absolute. So if you say to me, are the prettier embryos the ones that perhaps get biopsied more routinely? That's probably a yes, but not all of them are certainly not that morphologically normal looking. So there is the potential just to put back embryos that are of poorer quality, but again, it's very important to point out that their implantation potential is much reduced. So when we talk about PGS and the biopsy process on top of that, it's sort of standing on the shoulders of a certain modest level of pre-screening in terms of morphology, and then the PGS acts as an extra filtration level, if you will, for selection.
Okay, we've got two more questions here, I think, to cover. One is we get these high potential embryos, and then we have this gray area that we talked about, but we get some embryos that are obviously abnormal and are not destined to be transferred. What are the options? What happens to those embryos that are not going to result? We know they're not going to result in a pregnancy, or they're going to result in an abnormal pregnancy.
Well, those ultimately, and that's why it's so important for us to get very clear consensual direction from the patients that undertake therapy with us when PGS or PGD is involved. It's very important for us to clarify that any embryos which are deemed of very low potential reproductively, that a couple are prepared to discard those, and we have very clear protocols for undertaking that. But that's part of the biologic process. It happens all the time in nature. The majority of normally fertilized eggs in the body do not go on to make a healthy live-born child. So we are just exposing that sort of biologic wastage, if you will, in the lab. So there's certainly a need for a couple to understand that not every embryo that we generate, and that certainly after it gets biopsied, morphologically it may screen itself out, it may just simply stop developing. But certainly once we have a clear indication from PGS screening that an embryo seems abnormal and of extremely low implantation potential, then we certainly recommend that it's discarded.
So I'm going to go off topic slightly here in this last question for you. And in the past week, we saw a report how a lab in Oregon used a new technology called CRISPR-Cas9 in a situation where there was a dominant genetic disorder that for cardiomyopathy, a heart muscle defect that often leads to death at a young age. They were able, in the cells from this embryo, to correct it. And they did it by injecting this enzyme in this process actually before the embryo fertilized in with the sperm at the same time. Do you think that in the not too distant future we may, rather than look at which embryos to transfer and which ones not, that we may be able to go in and say, this one needs a little nip and tuck here, this one has cardiomyopathy, or this one has cystic fibrosis, let's fix it?
I am in awe of the development of this technology, being able to go in and basically splice out a defective gene and replace it with a normal is it's profound stuff, and it certainly rings a lot of ethical warning bells for many people. But having been in assisted reproduction for 35 years now, having gone from an era when in vitro fertilization itself, even just the bare bones technology, was deemed inappropriate ethically, morally, I believe that this form of genetic engineering in the right hands and for the right justifiable medical reasons is certainly on the horizon. I'm very excited to embrace it in very conservative manner, but that it uses the game changer recently was, as you mentioned, the injection of the additional CRISPR-9 and being able to fix it at the time of ICSI, the sperm injection. We're doing that, undertaking that anyway, to be able to actually incorporate it in the routine procedures in our lab now is clear, so it's not an additional procedure. I think it's game-changing. So as long as it comes in conservatively, I'm all for it, for medically justifiable reasons. So.
Okay, well, thank you, Dr. Tucker. This has been an enlightening discussion. If you've enjoyed this discussion, we will have it posted online. You can share this video on your wall, and that will help other people have an opportunity to see it. You can subscribe to our future topics, and we don't have our next topic up, but if you subscribe, we will not inundate you with email, but we'll let you know when we've got another one coming. Actually, at the end of September, we are going to have a PCOS Awareness Month event on polycystic ovary syndrome, and we'll send out information on that. If you have questions, please don't hesitate to contact us, and we'll be glad to try our best to get you an answer. Thanks again.